So good afternoon, and thank you very much for inviting me. And I'm really talking on a whole different subject. But what I hope to be able to sort of do today is talk about some of the similarities we had in trying to understand our population, the challenges we were faced, and what we've been doing to sort of try to understand a population that really, and I'm going to focus on really with their respiratory symptoms. So I don't have disclosures. What I want to talk to you, because it's such a different population, is give you an overview of the World Trade Center toxin exposure to community members. So I'm really talking about civilian community members, not the responders. The challenges we were faced with assessing the respiratory symptoms in this population, and some of the physiologic, touch on a little bit of pathology and imaging, but really focus more on how we looked at these patients physiologically. So just to go over and review with you, the World Trade Center collapse or destruction was an environmental disaster, and it was a disaster for the civilian community who were at risk for exposure to dust and fumes. And I show you this just to remind you, but I show you this as a picture of the dust cloud. And this is to show you that we think that there were about 300,000 local workers, office workers, commuters, teachers, children, residents and students who all had potential for exposure. And this is a picture of the dust cloud. It's approaching Chambers Street. I don't think I have a pointer here, but what you can see there, there's a high school right there, there's an apartment building right there, there's a Borough Manhattan Community College right there. So this is clearly an area where there are a lot of people having activity. The first question that, of course, we had to ask was really what were the respiratory hazards, what were the characteristics of the settled as well as the aerosolized World Trade Center dust. And a lot of this work was really done by someone in this panel, Langone Chen. And really what we now understand, and of course this takes time to understand that, that there were about 10 million tons of material. Most of the settled dust was large. This becomes very important. A small part of it was smaller, but still a large part, was less than 2.5 micrometers. What we learned pretty soon after the event was that the dust was also very, very alkaline with a pH of 9 to 11, and it was predominantly from construction materials, concrete, gypsum, synthetic vitreous fibers, etc. We also, over time, began to learn what the chemical components were, that most of them were combustion products from jet fuel or from building materials, including all the computers, construction debris, and there were a lot of things in there, including polyaromatic hydrocarbons, PCBs, et cetera. The point being that there was very complex components in this dust. So one of the other key things about this dust was that it was very easily resuspendable, so it could aerosolize very, very easily, and that became important when we started thinking about respiratory issues. We also knew that, and like you, we had a lot of difficulties understanding exactly what the exposures were. We had a lot of issues with air quality monitoring, issues with early protocols, location of sample sites, methods of measurement. All of those went in to create actually a fair amount of confusion. And Ground Zero was not declared a hazardous waste site or a Superfund site, so this allowed for reduced protection requirements. And certainly for the people who lived and worked down there were no legal responsibility for assessing or addressing indoor environmental contamination until about 1 year later. So many people were left to actually contend to the contaminants themselves, and the recommendations from New York City were to damp mop, so there wasn't really a lot of guidance. So our question was first how to characterize exposures in the World Trade Center community members, and we really have done that quite coarsely. We talk about acute exposures, so this is a group of individuals who had acute dust cloud exposure. We talk about chronic exposures from the resuspended dust. These are people returning back to work on 9/11, so that's not that's 7 days later, so that's not snow on the ground, it's September. We talk about people who had indoor exposures. These are some of the local residences, and this is the dust that collected there. And we do know that that dust was very similar to the outdoor dust, although the quantity of smaller particles was probably greater. And then we know that there was chronic exposures from the gases and fumes. So that's sort of a coarse categorization of how we think about the exposures themselves. And so pertinent, I think, to the Gulf War exposures, we know we had mixed exposures. We know we had a delay in toxicant characterization and we have a lot of difficulties characterizing dose. So we began very early on to have reports of adverse health effects in the responders. We had much more delayed work in the community members. And what I'm going to talk to you about today is really the lower respiratory effects. And those we first actually characterized in the first residence respiratory health study, which we did started within months after 9/11, and this was a collaboration with the New York State Department of Health. And this was a cross-sectional study of a sample exposed population and a controlled residential population. There were people right around the area, and then there were people on the Upper West Side of Manhattan. And we completed this study within 16 months. And what we were able to show is that these residents reported new onset respiratory symptoms. And we focused on symptoms rather than conditions or diagnoses because we felt that many of these people would not yet have been diagnosed. And we did all sorts of respiratory symptoms from cough, shortness of breath, wheeze, chest tightness, etc. And because nobody, as you know, self-report can be very questionable, we also looked at unplanned medical visits, fast relief medication use, controller medication use, and again, these were all increased in this population. So this was really the first report of increased lower respiratory symptoms in this population. Subsequently, the New York City Department of Health created a registry, the World Trade Center Health Registry, of about 70,000 individuals, and this remains an ongoing cohort. And they, in fact, confirmed many of these new onset respiratory symptoms in this population. You can't see this, but what I want to show, or just say here, is that we tried to do a dose response, and working with the New York City Department of Health and their registry, we were able to show that both acute and chronic exposures were associated with lower respiratory symptoms. This was from our first study, where we showed that new onset symptoms were associated with the persistence of dust or odors in the home. You can see new upper, new lower, new persistent upper, and new persistent lower, that is at the time of the study, were all associated with dust or odors in the home. So as a result of this, we actually eventually created a multidisciplinary treatment program for community members with presumed World Trade Center-related illness. The target population was local residents, local workers, students, and cleanup workers. It started really as a small program in a public hospital, Bellevue Hospital, City Hospital. We were eventually funded by the American Red Cross, then the City of New York, eventually the CDC NIOSH, and now we are a program under law, the James Zadroga 9/11 Health and Compensation Act. And the reason I say that is because what that lets you understand is the differences and the challenges in terms of obtaining data, depending on the funding, depending on how we were being funded. For example, when we were a CDC NIOSH program, we were not supposed to do research. We could only do CDC non-research. So there are a lot of challenges we faced in how we were able to get information. The other challenge we had is that, of course, when we wanted to study this population in our program, it's a self-selected population. By law, patients have to have aerodigestive or mental health symptoms in order to enroll. By 2011, they could also come in with cancers, so we're now getting a huge number of self-referred patients with cancers. All patients undergo standardized questionnaires, including exposure assessment, PFTs, mental health screening, as well as a whole variety of other testing. And the treatment, as I said, is a multidisciplinary program. And to date, we have about 11,000 individuals who have enrolled in the program. So our problem really was how to characterize objective findings in a large population reporting lower respiratory symptoms. And we focused at first really on physiologic assessments. And of course, we include spirometry, forced vital capacity, expiratory volume in 1 second, as well as spirometry pattern. We knew that the firefighters were reporting a decline in lung function, but unlike us, they had pre-existing measures, and they could really look at this. But despite their decline, when they looked at their lung function, most of them remained within normal. So again, that's why looking at longitudinal in these populations becomes so important. Unfortunately, we had no pre-existing measures available for this community population, and in fact, it's a little hard to see here, but over and over and over again when we looked at them, and here I'm showing you one study we did where we looked at patients with no lower respiratory symptoms, those who had mild, severe, or severe, and regardless, down below, when you looked at them, most of them, 60 to 70%, had a normal spirometry pattern or had normal lung function. So this created a problem for us. How are we going to understand the symptoms in this population? The firefighters have been reporting hyperresponsiveness. We tried to do a methacholine challenge in many of these patients. It was really too cumbersome to do in this large volume in our city system. We did do it in some small subgroups, and over we found that about 50% were positive, depending on the dose of methacholine that we used. However, early on, we had a firefighter present to our ICU, and this was actually within 2 weeks of the event, and he had an abnormal CAT scan, as I show you here, and we had a very aggressive group at that time. They bronchoscoped him. This is Bill Rahm. I think some of you know him. And what we found is very important, which is, in fact, we could find particles, and I'm showing you here an asbestos fiber, fly ash particle, degraded fibrous glass. But I think the critical thing here is really that these are very large particles, and they're large particles that have managed to get through all the protective mechanisms and get deep into the lung. And that becomes very important because it suggests to us that our dogma of only small particles getting deep in the lung may not really be correct when one is exposed to massive exposures. The other issue we had was when we looked at the abnormalities, the most common abnormality we had was not obstructive airways issues, but really a reduced vital capacity. And we tried to get a hold of biopsy specimens, and we were not doing them routinely in any of these patients, but we did look at a small segment of about 6. And I think the important thing we learned from that is that we'll never get 4 pathologists to agree with each other. So I'm not even going to really say much about these other than that. They were done, this group was done in a group of patients who had really normal CAT scans except for air trapping on the CAT scan, which I can't point. And really the key thing was nobody could really agree on what they were seeing, except that most of them had small particles deep in the, actually relatively large particles, but particles deep in the lung, and that many of these were birefringent particles. And when we sent them off for particle analysis, they had odd things in them, metals such as steel, copper, and chromium, suggesting, certainly not proving, but suggesting that these were unusual particles and could have come from some of the inhalation from the dust. So this suggested to us that we really needed to focus on small airways evaluations to understand perhaps what was going on in this population. And we then sought collaboration with a group with our physiologists, Ken Berger and Roberta Goldring, who taught us all that, in fact, spirometry doesn't really measure the smaller airways, that these really are in the quiet zone, and we needed to do something else to detect abnormalities in the small airway. And so at that time, there was a commercially available impulse oscillometer. You heard a little bit about this today, where one can do what's called forced oscillation evaluation. That's a non-invasive, simple maneuver at tidal breathing, and it measures resistance directly by measuring the relationship between pressure and flow at different oscillating frequencies. And you can assess this at different oscillating frequencies and can give you identify non-uniformities in airflow distribution, which can be considered a hallmark of small airway dysfunction. And there's a lot of measures one can get. What I'm talking about today is R5, R5 minus 20. There are clearly other measures that one can do using this. So the first question we asked was, do these measures relate to measures of small airway dysfunction using what we considered at that point the gold standard of small airway dysfunction, which was a technique that employed esophageal manometry. And what you can see here, I guess this doesn't point, is that frequency dependence of compliance, FDC, is shown as abnormal on the right. And you can see that both R5 and R5 minus 20 measures are elevated when you have the hallmark of small airway dysfunction or frequency dependence of compliance, suggesting that this could be a measure of small airway dysfunction. And so we routinely incorporated IOS measures in all lung function evaluations of patients coming into the World Trade Center Environmental Health Center. It was rapid, effort-dependent, even in our population, relatively easy to perform. But we had a huge problem in trying to analyze these data, which is that most of our patients had lower respiratory symptoms, and almost all of them had abnormal IOS measurements. And so we couldn't really interpret the data because we didn't really have a control population. So we collaborated with the New York City Department of Health, who were about to embark on a field study of their registry patients, and we did a case control study looking at symptomatic cases and asymptomatic controls. All of them had been exposed, but these were patients who either had repeated symptoms, reports of symptoms, or had no symptoms. And we performed spirometry and impulse oscillometry in the field. So in other words, one can do this in the field. It's actually relatively easy. And we compared lung function between these cases and controls. And what we found is that, in fact, as expected, as shown in blue, most of these controls and cases had normal spirometry. And that's what we've been seeing over and over and over again. But if we looked at the impulse oscillometry measures, what we could see on the left is your controls. On yellow are those who had abnormal oscillometry, and in fact, some of the controls have abnormal oscillometry, but many, many, many of the cases now have abnormal oscillometry. And we could show, in fact, that these abnormalities were also associated with World Trade Center exposures, although I'm not showing you the data. And this suggested to us that, in fact, this could be used to help us identify and understand what these measures were showing us. So we went back to our clinical population and used our controls here in our clinical population. And what you can see here is in blue are our symptomatic clinic population compared to the clear values, clear bars, which are our control population. You can see over and over again that they are more elevated in our clinic population. What we also did was stratify it by BMI, because we know that BMI will really impact on your iOS measure. And despite that, one can see that our symptomatic patients were repeatedly had higher levels than our asymptomatic. So this suggested to, and this was in our patients with normal or preserved spirometry, as well as those with abnormal. We also were able to show that there was a trend with various symptoms. Here I'm showing you wheeze, but as you went by wheeze severity increase, you could have, there was an increase in both your R5 or R5 minus 20 values, and also if you went by wheeze frequency, for example, one could also see an increase, suggesting that, again, there was a relationship with symptoms. So this suggested to us that forced oscillation techniques, here we used iOS, could be performed easily in the clinic or field. It's a useful tool as an adjunct to standard lung function measures for assessment of lower respiratory symptoms, particularly in those with normal spirometry. It's relatively easy, it's effort independent. There are normative data that are available by Ustveen, and we're about to publish ours as well. However, the interpretation is confounded by BMI, and it doesn't reveal the source of abnormality, whether that abnormality is in the chest wall, parenchyma, pleural, or even the airway. So we had hoped to be able to also do imaging, and early studies came out showing, in fact, that in the responders, one had air trapping, as shown on the right, in CAT scan evaluations. And in fact, part of our routine evaluation in someone who has an abnormal lung function by spirometry or unexplained symptoms that are severe is also to do an inspiratory and expiratory CAT scan. But we actually had a lot of trouble really carefully quantifying this, and so we can't really report on that. We did look at it in a small group, and I don't think I'm really going to go over this except to say that this group always, if they had a reduced vital capacity, they often had a reduced expiratory reserve value, and we used to call that the icy dyspnea. We knew when they had that they were going to be short of breath, that they had no ERV. And if we looked at a small group, you could see in this group who had a reduced vital capacity, they had a reduced expiratory reserve volume, they had elevated RV-TLC, slightly reduced TLC. We did compliance studies. They did not have stiff lungs. And they had imaging studies, again, showing some air trapping, but we couldn't really quantify that. However, there are now new methods for CT evaluation. There are ways to quantify large airways. There are also new ways to quantify small airway, particularly a measure called parametric response mapping of functional small airway abnormalities, where one can look at paired inspiratory and expiratory CTs to quantify the extent of small airway abnormalities. This is commercially available software. And very importantly, in the COPD studies, it's been shown that you can have abnormalities in this imaging technique in the presence of preserved lung function. I think this becomes very important. And a recent study showing, in fact, that you can have these abnormalities even in patients exposed to vapors, gas, dust, or fumes. So I think this becomes a very interesting technique as we move forward, certainly in our population, but also in other populations. We were very interested in doing blood biomarkers. I think your statement about chronic symptoms becomes very important. The firefighters had blood that they had from very early on. We've never had that. We've never been able to create a repository. When we go back to this firefighter, one of the other important things, and I think that's pertinent to a description this morning, is that he in fact had an eosinophilic pneumonitis. He responded beautifully to steroids, and he's alive and well and doing well today. So we presumed that we would see a lot of eosinophilic disease, and we would see a lot of high blood eosinophils, and we actually never saw that. We saw that in a very, very small proportion of our patients, and when we did see it, it was usually associated with those who had an obstructed pattern on their spirometry. We had a few cardiologists working with us at one point, and so we did, in fact, CRP measurements. We had to say that these were clinically indicated. CRP measurements in this group, and that was a very different, and again, these were in people with chronic disease, so not predictive of a disease, but that was a very different pattern, and we think it was more associated with low vital capacity and also with an abnormal iOS, but again, that's pretty preliminary. So in summary, many community members with World Trade Center dust exposure had lower respiratory symptoms. They were out of proportion to screening spirometry. There was a lot of heterogeneity in this population and in the diagnoses that were made. The bronchoalveolar lavage and pathology studies suggest the ability of these even large particles to reach the distal lung. The lung function findings, the reduced vital capacity, forced oscillation, air trapping on CT, are all consistent with abnormalities in small airways, even in those with normal spirometry. And the common blood biomarkers were associated really with subtypes of characterization. So we had a lot of challenges with the assessment of environmental lung injury. I think many of these are pertinent to what you're discussing today. A lot of it has to do with variability in individual clinical response or heterogeneity. Standard measures of lung function may not be adequate. We may need to look at other things, including airway hyperresponsiveness, measures of small airway function, physiologic measures, as well as imaging, and also, as you've heard, a lot of comorbidities, including upper airway and mental health. And these are critical, particularly for us and for you, because they all impact on how we're going to treat these patients. So thank you very much. I'll be glad to take questions.
Thank you, Joan. Interesting talk, and certainly considerable relevance to what we're discussing today. Questions, comments regarding this presentation?
I was hoping there'd be none.
Initially, Lung Chi Chen had been talking to us a lot about World Trade Center stuff, and I had a lot of trouble trying to think of the relevance of a lot of it. But I'm convinced now that actually it's a good model for what we're studying, even though the time course is quite different. It's a one-shot sort of exposure, except for the persistent exposures that you described. Perhaps more relevant than cigarette smoking or other exposures that we might consider. So it is, in fact, sort of a good model. And it's also this complex exposure that is also characteristic of what we're interested in here now. Other parallels are the struggle to find appropriate control groups. I mean, and a lot of what you have lots of data. Lots of it is descriptive because you're not having, you're having some trouble with that proper control group. You did, with your community study, you did have, I think nice controls for that work. But some of it is also plagued by the same challenges that we're faced now with a number of studies. This issue of proper controls, and I'd like to have maybe some comments from you regarding that.
No, I completely agree that having the appropriate control is really critical. The first study we did, we actually had the first study we did to first show that there were even symptoms. We had a control group, which was the Upper Manhattan unexposed group. We matched them by buildings. We did all sorts of things to make them similar. But we have had, again, one of the problems we have is that we're in a clinical program trying to do research, and that's always a problem. And on the one hand, we have the benefit of being able to do standardized assessments. On the other hand, we don't have a good control group. So I think really identifying those is going to be critical. And we're faced with that even more now when we're starting to look at cancer issues. So that's a very, very key issue that you're seeing.
I was going to say something very similar, that especially as you're looking at cancer, and as you said, now we're beginning to see these cases, making sure how to design this for adequate controls is really going to be an interesting question, because as the population ages, you're going to see more of these kinds of malignancies and so on. I was also trying to think about how you set up your controls for looking even at oscillometrics, and what is the right control population? Is it just healthy people, or is it those who have some type of exposures? And I'm assuming, for example, smokers who have normal normal spirometry have abnormalities in their oscillometrics.
Again, it's variable. We excluded smokers from this study that I showed you here, again, because we were actually interested in those who were non-smokers, but smoking, of course, will modify what you're seeing. Again, how do you find the appropriate controls is very critical, and I think the important thing for all of us is, so we're a clinical study, and we can't really do controls. So is again the concept of sharing and reaching out to other groups. So we reached out to New York City Department of Health, and that was exposed population who were or who were not symptomatic, and we excluded the tobacco smokers in there as well. But we really, and now there are normal values that are out, but again, whether that's a similar population is very important. So it is important. I mean, I completely agree with you. Controls are key.
That was really helpful. Just again, on this issue of exposed, everybody, the controls exposed, but the not symptomatic, and then compare them to the symptomatics. And then iOS actually differentiated those two on the basis of exposure.
Symptom, but was related to exposure as well. Right.
And, it's a little bit different with the firefighters, as you pointed out, and as has been extensively reported, where they had that profound decline in FEV1 of about 600 cc's, but then they flattened back out to an age-related decline in FEV1. And I'm wondering, but we're still within the normal range. So it was a profound decrease, but you wouldn't see it if you didn't have the pre-exposure spirometry and that longitudinal data that David Prezant has described. And I'm just wondering if you can comment on, this obstruction, the vital capacity and small airways effects that you're describing in the probably much less exposed community group, although maybe not. Comment on that. And then if you could just share also whether there's small airways effects in the firefighters. Besides that large decline in FEV1, what do we know about their small airways?
That's a lot of questions. Okay, let me see if I can break them down. First of all, what were the questions now? First of all, so the firefighters had a rapid loss and then they sort of declined. We actually did 2 longitudinal studies, and in fact what we see is some improvement in lung function over time in our group, but again it depends on what the underlying abnormality was. So those who have really severe lung disease, they go in all different directions. Many people got a little bit better, but it's a treatment group. We are treating these people as well, so it's a little complicated. But we don't see that continued decline in everybody. I mean, again, there's a lot of heterogeneity in there. Second of all, your question was in firefighters. Yeah, well, David Prezant for a long time didn't really want to do these studies. But the interesting thing was that what every group was seeing, whether responders, firefighters, or us, was that if there were abnormalities, they were abnormalities in the vital capacity. But you weren't seeing the other abnormalities that you would expect to go along with interstitial lung disease or something like that. So, and in fact, what I didn't show you quickly was that the compliance is different. And so the thought, and that these reductions in vital capacity were also associated with air trapping. So the thought was that this was probably small airways disease as well.
But we don't know in the
I think they just came out with a paper, but I can't, not sure.
Other questions or comments? Sorry.
One other thing, I want to agree with you in bemoaning the dogma about small particles and deposition in the alveoli. You know, it's well known that there's a bimodal distribution in size and deposition in the alveoli. At least it goes up to 5 micrometers in diameter. What isn't so well appreciated, what you're alluding to, is that even particles larger than 5 micrometers might gain access to the alveoli, which would be very dogma breaking, even for me. but it is well known that it's not just ultrafine particles and submicronic particles that make it to the alveoli, but there's another mode of particle sizes up to 5 micrometers that easily make it down to the alveoli.
You know, I would just like to say that some of it, these are massive exposures, and I think some of it is how one is exposed as well.
That cloud is very impressive. It's hard to imagine how you wouldn't get everything in your deep lung from exposure to that kind of contamination. Meredith?
To make one comment, based on how we could think about applying this to Gulf War exposures, and one, the instance that these are ongoing exposures, and so in one sense there's an opportunity to be collecting data that might be helpful following people over time. Just comment on that. And then also thinking about whether there may be something that we can learn from the World Trade Center group about synergistic risks after the exposure. And what I was really thinking about was in a military situation, you may have people that are deployed and then deployed again, and whether there are risk factors that may be multiplicative or cumulative, and how, for example, if there are individuals or subgroups from the World Trade Center that either through smoking or other occupational exposures that had different or worse clinical courses, could we apply that type of knowledge? Any type of comment?
So first of all, I think the thing about FOT, and I'm looking for the New Jersey from Michael, is that you know, it's relatively easy, and you can do it in the field. So you can do it repeatedly, and you can do it in many, many people. I mean, for us to be able to do this in the field with our really difficult to manage population, to do it in our clinic where we have people who have less than a 6th grade education and stockbrokers. So, you know, you can do it pretty easily. You have to interpret it. It's complicated to interpret, and you have to put all of those things in the pot. I think your question about other comorbidities or co-exposures is key. And when we looked at our longitudinal study, the people that got less well or declined were often the smokers. So here I didn't show you the smokers, but in our longitudinal we included our smokers as well. And again, so clearly multiple exposures becomes very, very important and something to think about.
Thank you.